Yes, madam.
Assalamu alaikum and good afternoon. Welcome all today's cardiac webinar about hypertension update to 2020 and real-time experience about hypertension. Today we have two legend keynote speaker with us. One of them is our Professor Mohammad Nazrul Islam, who is the Professor of Cardiology, and another speaker is Professor Mohammad Zakir Hossain. He is a Professor of Medicine. First of all, uh, I welcome uh, I welcome for a welcome note which will be given by Mr. Shah Nawaz Khan Riza, who is the head of commercial excellence and specialty care business, Sandoz Division, Novartis Bangladesh Limited. I welcome Mr. Shah Nawaz Khan Riza.
Thank you, Dr. Shana. First of all, honorable speakers of today's program, Professor Dr. Nazrul Islam and Professor Dr. Zakir Hossain, and all the distinguished guests present in this session. Assalamu alaikum and a very good afternoon. Uh, uh, from Sandoz, we always feel privileged to be a part of this kind of initiatives. So we always value scientific and knowledge partnership with our honorable doctors and the healthcare professionals. এবং আজকের সাইন্টিফিক সেশনটাও has been arranged with the same proposition, obviously. We believe that this kind of experience sharing sessions are really important for all of us, and especially for the doctors in this continuously changing dynamic environment to keep ourselves updated. And that ultimately helps the patients in the country, which is the objective for all of us to serve the patients. So that's why we are here. And Sandoz, as a global leader in generic and biopharmaceuticals, is also committed to ensure high quality, affordable medicines for the patients of this country, and which also supports your professional practices. I'll not take longer. So I would like to again convey my thanks to all the participants of today's program for being here, despite your entirely busy schedule. Among special thanks to Professor Nazrul sir and Zakir sir for putting the presentation together for today's program with a lot of effort, we know, and on such an important topic. So thank you, sirs, again. এবং আমি আশা করি that this scientific session will add more value to our knowledge and practices through these presentations and the discussion that will happen. I will not take much time. So wishing all of your active participation to make the program more effective. And thank you again for all of your participation. So thank you.
First, we have divided our today's webinar into two sections. First, speech by Professor M. Nazrul Islam Sir, who is a professor of cardiology, is also former director of NICVD NICVD, and he's also worked in the former as the professor of cardiology as BSMMU. He also acted as a professor of cardiology in the University Grand Commission. He is a legend of cardiology, not only in our local arena, it also is in the international arena. He is not only a cardiologist, he gives service to the patient as well as to the student. He has a lots of follower students in locality and internationally. It is my I feel highly honored and privileged to welcome him for his speech, today's speech, and so time demanding speech about the update of hypertension 2020. I welcome and I request Dr. Professor Nazrul Islam sir to for his speech. Professor Nazrul Islam sir.
দেখা যায় স্ক্রিন না?
না স্যার, এখন দেখা যাচ্ছে স্যার। হ্যাঁ,
এখন দেখা যাচ্ছে না? ঠিক আছে,
জি স্যার, দেখা যাচ্ছে স্যার। জি স্যার।
ওকে। Assalamu alaikum. Welcome everybody, especially Professor Zakir, Professor Shahabuddin and Shahana and all other participants of this webinar. Actually, I will describe very briefly in today's presentation about the hypertension update of 2020. And I will try to put the guidelines into practice, how we can utilize the guidelines. Though there are many differences between the guidelines, how can we integrate it and how can we put it into practice? So, as you know that hypertension basically is a chronic disease condition, and which is very important because to control this particular disease is we must put our all effort to minimize or to protect the different vital organs of the body. So throughout my presentation, I will discuss very shortly about epidemiology and its pathophysiology, and how to diagnose and how to clinically evaluate the patient with hypertension. And in the management and therapy section, I'll discuss something about the clinical practice guidelines available till today, and some non-pharmacological therapy, and mostly I will discuss on the pharmacological therapy in different aspects of hypertensive patient. As you know that globally, hypertension is prevalent of almost about 25% in the adult population, and they are hypertensive at the moment all over the world, and of which the number of which increase of the 29% about, it will be around 1.56 billion by the year 2025. And it is very interesting to know that almost 75% of the worldwide population of hypertension will be living in the developing countries. So, though hypertension is a problem of global interest, but is more important as a problem of the developing countries. And this will give an annual cost expenditure around about $370 billion worldwide yearly. So we can gaze about this brilliant disease, which is very giving a global economic burden also. So, and most of the patient with hypertension, they may develop, sorry, sorry. Sorry. So, as you know that most of the hypertension patient, they have got the leading risk factors for the cardiovascular disease, death, and disability globally. We know that hypertension is a disease condition, or you can take it as a syndrome, which gives rise to a lot of complications as becoming the important risk factor for this. So if you can see over here, in the cardiovascular system, the hypertension patient develop left ventricular hypertrophy and ultimately failure, coronary heart disease, and heart failure. In the renal system, we have got chronic renal disease and ultimately to renal failure, and may need transplantation and dialysis. And that another important aspect is the peripheral vascular disease, and of course retinopathy and blindness, and in the cerebral system, TIA and stroke. So if you look in this carefully, that all these complications are vasculopathy related complications of different systems. And you can see that the complication of hypertension are thought to cause about 9.4 million deaths each year. So per se, hypertension may not be thought of as a devastating organ or a fatal disease, but with its complication, definitely it is fatal, which is about 9.4 million deaths each year worldwide. But about hypertension, we have got few paradoxes. What is the paradox? This hypertension is very easy to detect, but diagnosis rate is very poor, as you seen in various studies. I think these patients are very easy to treat, but treatment rates are disappointing, as has been documented by a lot of patients with uncontrolled hypertension. But there are several potential drugs available in the market for clinical use, but control rate is extremely bad. So this is what the hypertension is. We think that hypertension is easy to treat, but however, practically we have seen that we cannot control blood pressure properly or adequately, and we have seen a lot of patients with complication of hypertension. Very simply, we can describe pathophysiology of hypertension because it is very complex and heterogeneous. Not all hypertensive patients have got equally or the same pathophysiological process, but the important related factors are the changes in the sympathetic nervous system and or renin-angiotensin system. There are certain evidence of renal dysfunction, and of course, there is genetic and environmental factors are there. Therefore, since they have got different types of heterogeneous group of pathophysiological characteristics or factors, the management of hypertension needs more antihypertensive drugs and approaches which must be integrated to control hypertension and to prevent complication. This is one of the cartoon from the WHO where development of hypertension in its complications are shown here. So if you see, there are certain social and detrimental drivers are there, like say globalization, utilization, urbanization, aging, education, housing, etc., and income. And that may interact with behavioral risk factors like unhealthy diet, tobacco use, physical inactivity, and harmful use of alcohol. And again, all these again interact with some metabolic risk factors. This is very important, of which high blood pressure is very important. Of course, it is associated with obesity, diabetes, and raised blood lipids. And from this, when all this complicates, and they given rise to cardiovascular disease like heart attacks, stroke, heart failure, and ultimately to kidney disease, renal failure. So, to understand the basic pathophysiology and physiology of pathology of hypertension, we must understand all these different factors which give rise to cardiovascular diseases. In the diagnosis, actually, we depend solely heavily on some clinical practice guidelines, but we must remember that these clinical guidelines provide a population-based minimum standard useful in treating most patients, but not all patients. And this should not be substitute for good clinical judgment or the judgment by the expert faculties of the profession. And individual patients and unique circumstances may mean guideline exceptions. So there are certain exceptions from the guideline. So guideline can give rise to the guides of how to treat the patient, how to diagnose the patient. We should remember guidelines are guidelines, not the law. So there are a few guidelines you can see over here. We can have the recent guidelines, 2077 guideline of American College of Cardiology and Heart Association, 2018 guidelines of ESC and European Society of Hypertension, and a very recent guidelines by the International Society of Hypertension. We have got also guidelines from the Canadian side. We have also guide from the UK as a nice guideline. And almost a forgotten guidelines from Bangladesh is here. This was proposed in 2013. However, with these few guidelines, I will try to summarize the practical aspect of hypertension management. So if you consider the definition, classification of hypertension, you can see the changes from 1997 for JNC 6 to different guidelines. So they changed this guideline in 2003. I am not going to detail, just they have changed the original pre-hypertension stage into pre-hypertension optimal. And and ACC-HI guideline 2007, they drastically changed it. So I like to give importance to these particular changes, which is not always accepted by globally. Then ESC and ESC guidelines, they remain the same classification and the guideline standard. And this was the Bangladesh guidelines, almost the similar with this, except the pre-hypertension included. So this was the current situation till now. So you can see of all the guidelines, this is totally a different guidelines because their hypertension level have been redefined, which is not acceptable by many of the major guidelines of the world. So when this guidelines was first published, there was a reaction from the International Society of Hypertension. They asked the question, are the American Heart Association, American College of Cardiology high blood pressure guidelines fit for global purpose? Thoughts from the International Society of Hypertension. And this article, the opinion of the International Society of Hypertension guidelines were like this. We suggest that in the global context, the definition of hypertension should remain as systolic blood pressure more than 140 millimeter mercury and diastolic blood pressure more than 90 millimeter mercury. This was the first reaction from the International Society apart from the guideline by the American College of Cardiology and Hypertension Association. So why they have done it, and they have put three important things which they describe as context and purpose. Number one is to be used globally. They try to formulate a guideline which can be used globally and to be fit for application in low resources and high resources settings by advising essential and optimal standards of care, meaning that we have got a different type of countries like low resources or high resources. Such a guideline can be used in both places, because even in high resources countries there are communities which are low income resources, so they can use. And they divided the guidelines into essential part and optimal part, meaning that some characteristics, some investigation facilities, some medication must be essential for all patients, and if possible and the economy allows, there may be some optimal standards of care may be used by many countries. And the third one, to be very concise, simplified and easy to use by the clinician, nurses and community health workers as appropriate. As you see that about 60, 70, 80 pages guidelines of the British and the US Society of Guidelines is very difficult to accumulate and digest by every sphere of the people. So this was the aspect by which IASH has formulated this guideline. So the optimum care they refers to evidence-based standard of care suggested in research guidelines, and essentially is standard for minimum standard of care to allow significant specification of essential standards of care in low resources setting. So this is the aspect of this thing. So if we, in our country, we can use essential in the primary health care to the district hospital and optimal care to the tertiary hospital and the institutes, we can use those guidelines aspects. So now they have got classified again high blood pressure into normal, high normal, grade 1 and grade 2, there is no grade 3. So this is the classification of the present ISH guidelines. Now we can summarize if you want to remember. I personally remember three guidelines. One is ACC guideline, and the ESH guideline, and the International Society of Guidelines, and we see the differences here. So remember that. And in practice, I like to practice the International Society of Hypertension guidelines, which is much more similar to the ESC guidelines, except they have put together the grade 2 and grade 2 in the stage 1 to stage 2 hypertension. However, now how we can accurately diagnose hypertension? Definitely, we diagnose hypertension by some acceptable strategies for measurement of hypertension, and of which is office or clinic-based measurement is important. We call it OPBM or office-based measurement, which may be either manual or automated. Manual measurement is very quite common in this country, though automated is not yet started here. But I think for our country, manual measurement in the office is pretty fine. And of course, in some situation, we must use out-of-office measurement, either by home blood pressure measurement or ambulatory blood measurement. And you can see that in all major hypertension guidelines proposes out-of-hospital measurement to confirm the office and clinic findings. Why? We can say that. This is a very simple figure to see how we can measure blood pressure. So only I like to emphasize over here that office blood pressure should have 2 to 3 office visits at 1 to 2 weeks interval before we level measure hypertension. Whenever possible, the diagnosis should not be made on a single visit unless the blood pressure is very, very high, like 180, 110. And if possible and available, the diagnosis of hypertension should be confirmed by out-of-hospital measure. So these three important feature has been highlighted in the recent ICH guidelines. And how we can measure in the office measurement? Initial measurement should be measured in both the arms. Difference between 10 should be used as constant, but if it is more than 20, you must other investigation to find out the cause. Standing BP is necessary in treated patient with symptoms of postural hypertension and at first visit of the older and diabetic patient, because most of the time they may have postural hypertension. And unattended BP or automated BP is more standardized. Lower BP levels with uncertain threshold and out of office again needed most cases. So unattended BP in the office room can be measured in respect of out of office measurement if possible. So these are the definition of different guidelines about the blood pressure, clinical blood pressure, hypertension, definite level, either in the office level or in the home patient ambulatory level. So you can see only the difference is here the ACC guidelines. Otherwise, the ESA guideline, NICE guideline, ICH guideline definitions are same. There are some phenotypes of hypertension with corresponding BP measurement. I can see over here. With normotension, you know that office BP, out of office BP, and cardiovascular risk. So office BP, out of BP are normal for the normotension, and of course for this patient the cardiovascular risk is lowest. White coat hypertension, the office is high, the out of office is normal, and their risk is intermediate. Mask hypertension, where office population normal, but out of office is abnormal. It is a very rare one, but is very significant one. And this particular group has got intermediate or high risk. And definitely hypertension patient have both high value in the office and out of office. They have got that higher cardiovascular risk in future. There are also some other phenotypes like isolated systolic hypertension. I am not going to detail for this. Orthostatic hypertension and variable blood pressure. These three phenotypes sometimes create problem for managing hypertension in respect of the physician and also for the patient. And we must, after diagnosis hypertension, we must classify the patient as per their cardiovascular risk assessment, and this should be done very carefully because the combined treatment of hypertension and additional cardiovascular risk factors reduces the rate of cardiovascular disease beyond blood pressure control. So we must also think that only blood pressure control should not be the target of hypertensive patient, because at the same time their cardiovascular risk should be reduced. The therapeutic strategy must include lifestyle changes. We know that BP control to target and to effective treatment of other risk factors if there are present in the patient. So this is an important term. We must remember the hypertension mediated organ damage. Initially, when we are a student, we call it target organ damage. So these are the various structural and functional alteration of the arterial vasculature. I have told earlier in the beginning that most of the complications are vasculopathy. So these target organs include actually the brain, the heart, the kidneys, central and peripheral arteries, and of course the eyes. And these target organ or HMOD management should be important in therapeutic consider, because management for antihypertensive patients with low or moderate overall risk through reclassification due to presence of hypertension mediated organ damage, and preferential selection of drugs treatment based on the specific impact on the target organ damage. So this is important that we have to find out the hypertension mediated organ damage, and sometimes the medication, especially the pharmacotherapy, can be targeted to reduce the progress or to reduce the complication of particular patients. And the evaluation, actually, why we do the clinical evaluation? Because for the diagnosis and grading hypertension, to see if there is any potential secondary causes or not, to identify the factors potentially contributing to the prevention of hypertension, and we must identify the concomitant cardiovascular risk factor and diseases, and to establish if there is evidence of any hypertension mediated cardiovascular disease or not. So these are the main purposes for which we actually evaluate the patient. And this is common thing. Essentially, we must use this thing from medical history, physical examination, and for routine lab examination, mostly we use the hemoglobin, hematocrit, fasting blood, and some electrolytes, blood lipids, etc. And urine test and 12-lead ECG. So we try to do all this investigation because these tests have been identified as essential. But for In essential also, we can, these are the findings. I'm not going to detail. So 12-lead ECG, we should see about the left ventricular hypertrophy and cardiac problem. Urine, actually, we try to see the renal function, especially albuminuria. Blood count, creatinine, also to detect the possible renal disease, and fundoscopy for retinopathy. And these are the some advanced investigation to find out the HMOD. And these are echocardiography for cardiac structure and function. Carotid we see for, especially for a carotid plaque or intermediate thickness. Abdominal ultrasound usually see for renal and other finding and vascular organism. Pulse wave velocity, then angiography, then cognitive function for cerebral function and brain imaging. These are quite advanced, and this is not usually routinely done. But if there is any specific indications to evaluate this patient, we can do it as an optimal therapy. So this is how the present ISH guideline has classified the classification of the cardiovascular risk. They find it as high, low, moderate, high risk patient, and they consider the risk factors, number of risk factors, then hypertension, organ damage, CKD, and diabetes and CVD, cardiovascular disease. So with this, so if, for example, if somebody has got the high normal blood pressure, has got no risk factor, so their risk is low. But if they have got all these things, they have very high risk. So only the level of high blood pressure is not the criteria for a patient to how strongly, how critically, and how intensively we treat the patient. So we must consider its risk and risk factors categories. So management is very simple. The patient with hypertension, if we treat the patient, whatever may be the thing, the primary goal is to reduce the blood pressure. The all-cause mortality is reduced approximately by 15%. Stroke reduction is pretty high, 35%. The most important is the heart failure reduction is more than 40%, and myocardial infarction 20%. So this is what is important. So in the treatment of hypertension, two aspects is important: lifestyle modification and drug therapy. But the important thing we must remember that at what BP threshold we should maintain, and how low the BP should be there. That is, means that treatment target should be established for each patient, and what is lifestyle and drug treatment strategies should be given to a particular patient. Non-pharmacological therapy, everybody of us know that we must change the lifestyle changes first, and then if the patient has got high risk and grade 1 hypertension, they can be started and can be treatment beyond hypertension control with CVD or cancer prevention. So these are the non-pharmacological therapy, and lifestyle modification is often the first line antihypertensive treatment for almost all the patients. Modification lifestyle can be enhanced as the effects of antihypertensive treatment. So even the patient needs antihypertensive treatment, lifestyle modification should be for everybody, because that can potentiate the effect of antihypertensive treatment of any patient. Regarding lifestyle modification, we must reduce smoking cessation, weight reduction should be there, or avoidance of obesity should be there. There should be a regular moderate exercise, reduce stress, and we have to ask the patient to manage how to manage his stress, and be careful with the complementary, alternative, and traditional medication, little or no evidence. We have seen many times that sir, আমি তো তেঁতুলের রস খেয়েছি বেশি প্রেশার হচ্ছে. I think we should discourage this sort of traditional medications and traditional myths. So in medical therapy, we use mainly the prominent mechanism of these drugs actually are to provide cardiac, cerebral, renal, vascular benefit. This is important, four important aspects. In terms of CV production, different between drug classes exist, but they are relatively modest. So in fact, almost all drugs have got similar effect. Of course, they have got certain clinical balance one over another, but that is not that much more significantly now. So this is one of the guidelines by the ESC guideline here. High normal blood pressure, lifestyle modification should be started for all the patients, and they consider drug treatment only if there is a high risk and especially have coronary artery disease. Although stage 1 hypertension also there. Of course, in addition of lifestyle advice, we must seek immediate treatment if the patient has got this one and has got some risk factor. So this is where we must calculate the cardiovascular risk. And in stage 2 and stage 3 hypertension, in fact, in our in ICH guideline, both this group are combined. You look over here that both the group has got similar advice. So possibly there is no role for giving rise to another stage versus stage 3 because their guidelines are almost the same. So the treatment regimen, so we should start with one drug, or recently you can start with the dual drug. But one important aspect thing that each drug should be tried for at least 2 to 3 weeks, and in 2 to 3 weeks intervals you can change the doses or type of drugs. Many times we change the drugs too frequently. Initial dose should be almost half, and we should not change the drugs within 6 to 8 weeks of interval. And this is there are a few things we must advise. The choice of drugs should be influenced by the age, sometimes ethnicity, and maybe other clinical circumstances. And there will be influence of the other associated conditions like diabetes, etc. Long-acting drugs can take once a daily as preferred drugs. We should use once a daily dose. And when more than one drug is prescribed, we should see the single tablet and which drugs works on different mechanism of action. Once daily dose should be given during any time of the day. It is not that you have to take in the morning or in the evening or in the night. So this is the simple guidance from the ISH guideline. Here, when optimal pressure is needed, step 1 should start with a dual low dose combination. Especially, ideally, should be given in single pill, and usually by either the ACE inhibitor or ARB plus or calcium blocker. Step 2, if not controlled, then go for full dose of the same drug. Step 3 for triple combination, adding diuretics with this. And step 4 basically is resistant hypertension. And along with this, we can add with spironolactone to this. And if it is not controlled, then we must refer the patient to the hypertension specialist. And these are the great guidelines. So we must follow the ideal characteristic of the possible drugs, and we should use free combination first, and then possibly you can go for single combination. Thiazide diuretics or thiazide-like diuretics, if not available, you can use thiazide diuretics. Each alternative for DSP calcium blockers if these are not available. So there is a lot of flexible way how we can choose the drugs even in the low resourceful situations. So consider beta blockers at any treatment step when there is a specific indication for their use. For example, heart failure, angina, post-MI, AF, a younger woman, and or planning pregnancy. There is a myth that the beta blockers cannot be used. No, beta blocker can be used if we follow this, and this is even in the essential stage or in the optimal stage. So how often should we see the hypertensive patient? A stable patient, 6 to 12 weeks, blood pressure from 140 to 90, recheck after 2 months. If blood pressure is more than 160 to 100, recheck at less than 1 month. So after adjusting medication, allow 2 to 4 weeks to blood pressure to stabilize, and lab testing intervals depend on number of and type of medication and medical comorbidity is used. So these are the basic outline how to follow the patient. Treatment of hypertension is specific. Few cases I will discuss only. Regarding this, we can see the coronary heart disease, about the 50% of the patients with the CAD have hypertension. 15% to 20% of hypertensive LV must increase, and ischemic stroke about 77%, chronic disease 80%, kidney disease 8% of the hypertensive patient, diabetes 75%, and peripheral artery disease 74%. So you can look there are pretty comorbidities, and with the relationship with hypertension is pretty high. So we must remember this one. Hypertension and coronary heart disease, basically we need that there are a lot of patients are with acute MI. And the patient target should be 130 to 80, or if possible in the elderly, 140 to 80. RAS blocker, beta blockers are common drugs, and of course, along with lipid lowering and the aspirin. And the post-stroke patient, Mostly we must reduce the blood pressure to 130 to 80, and for elderly 140 to 80, RAS blocker, CCB, and diuretic should be used along with statins and antiplatelet like aspirin. In heart failure patients should be lowered to 140 but not below 122% if possible. RAS blocker, beta blocker, MRAs are drug. Calcium blocker can be indicated if the blood pressure is poorly controlled, and the ARNI should be indicated in treatment heart with the reduced ejection fraction as an alternative to the RAS blocker. Hypertension in the kidney disease, again the similar, blood pressure related similar, but any of the drug can be used, but the target blood pressure should be 140/90 or 140/80 in the elderly patient. And diabetes also the same. RAS inhibitor is an important drug for this, and a statin along with the glycemic control. And atrial fibrillation, beta blocker and non-DHP calcium blocker is the primary drug for rate control. Stroke prevention and oral anticoagulation should be started in the patient with hypertension and patient with atrial fibrillation. Lower limb ischemia or peripheral artery disease you can use RAS blocker, CCB, or diuretic. Beta blocker may be used, but this is not the first line drug for this particular disease. In the elderly patient, the patient of systolic pressure more than 160, reduced to 140 to 50. Fit elderly patient who can move over the age of 80 years, consider antihypertensive treatment. Target is systolic less than 140. If elderly patient more than 80 years, systolic pressure with 160 or more, reduce systolic blood 140 to 50, providing in good physical and mental condition. Remember, these patients are very fragile. We have to treat very carefully with this. All hypertensive treatment agents are recommended at any age, usually locally, like said, diuretic, CCBs are preferred. Those patients which has got isolated systolic hypertension. I remember this. So now at the end, some of the key points we can take home points is hypertension is probably the single most important treatable risk factor for cardiovascular disease. There is convincing trial evidence for benefit from antihypertensive drugs with reduced risk of stroke, microinfarction, and mortality. Detection, accurate diagnosis, and evidence-based treatment of hypertension are important to reduce cardiovascular events. Once diagnosed hypertension, patient should be treated with achieved target blood pressure as per age and comorbidity disease following any guideline. Non-pharmacology therapy with appropriate lifestyle modification is recommended for all patients with hypertension. Antihypertensive medication is recommended for patients with stage 1 hypertension who are at high risk for cardiovascular disease and patients with stage 2 or stage 3 hypertension as per EC guidelines. Choose antihypertensive medication based on patient's comorbid condition, contraindications, potential drug interactions, and adverse reactions, ethnicity and race, and patient preferences. Follow up appropriately to assess the possible adverse medication reactions and ensure that patients reach their blood pressure targets. Try not to drop diastolic blood pressure below 60 degree in patient 60 millimeter mercury in people with coronary artery disease. Evaluate each patient adherence to therapies and use team-based approach to improve blood pressure control and reduce hypertension-mediated organ damage and mortality. Lastly, the individuals with age more than 65 years is medically heterogeneous population, and a one-size-fits-all approach is not their best interest. Drug choices in the elderly are similar to those of younger people, with the exception of beta blocker, relatively ineffective with predominant systolic hypertension, and diuretics. Some older people may be intolerant. In frail elder people, those who cannot move by themselves, with very limited life expectancy, treatment decisions should be individualized, and cautious de-prescribing may be considered, because in this age group patients, some of the drugs can be omitted or de-prescribed. So we must be very careful about the patient. With this, ladies and gentlemen, thank you very much. I think I have taken a lot of time. Okay.
Thank you, sir, for your brilliant and wonderful presentation. As usual, you make a complicated and large update into simpler and shorter form. It is a very complicated and tough job and needs lots of time to give. স্যার আমরা কি এখন নেক্সট প্রেজেন্টেশনে যাব না কোশ্চেন আনসার দিব স্যার?
মানে প্রেজেন্টেশন শেষ করে নেই নাকি?
আচ্ছা আচ্ছা, তাহলে স্যার আমরা নেক্সট প্রেজেন্টেশনে যাই না স্যার?
আচ্ছা, হ্যাঁ বসুন।
And now it is our time for our next presentation. Here we will deal with another legend, who is a legend of medicine, of Professor Mohammad Zakir Hossain sir, who is just retired as a head of the department from the Bogura Medical College. He is a founder and president of Hypertension Center Research Center Rangpur. Um, he's though a lot of time he work outside the center of the city, but he is always update regarding patient management and teaching the patient, teaching the students. And today he gave lecture about his lifetime experience regarding the hypertension management. I welcome and I am the privilege to welcome Professor Mohammad Zakir Hossain sir to give his talk. Professor Zakir Hossain sir.
Thank you. Thank you, Dr. Shahana Jaman. Can I share the slide? Thank you. Thank you, Moderator Dr. Shahana Jaman, Assistant Professor Cardiology, NICVD. Honorable Chairperson and keynote speaker of this session, my direct teacher, Professor Nazrul, renowned cardiologist and clinician, good teacher, academician, researcher, and policymaker in health education, Professor Nazrul sir. Today's moderator, Dr. Shahana Jaman, my direct student, I was in Sir Salimullah Medical College. Today's organizer, Sandoz Novartis Bangladesh Division, and dear participants, Assalamu alaikum. It's my great pleasure to say something about hypertension and hypertension center in front of my dear teacher, my mentor, Professor Nazrul sir. Sir, in details, elaborate hypertension, epidemiology, presentation, investigation, complication, and treatment. So, I have nothing to say. Still, you all know hypertension is a chronic, incurable condition. And in 2009, WHO declared it as silent killer. And it is one of the most important risk factors for heart disease, stroke, kidney disease, blindness, and peripheral vascular disease. So, by preventing the development of hypertension or by treating hypertension, we can reduce this significantly. Communicable diseases already controlled in greater extent, except COVID-19 in recent era. But NCDs now threat to the community. You all know around 72% of total death in the whole world due to NCDs complication. And hypertension is one of the important components of NCD. Prevalence of hypertension gradually increasing day by day. And now it is around 25% or more than. In 1976, it is only about 1 to 2% prevalence in Bangladesh. And estimated 1.13 billion people worldwide have hypertension, and most of them, around 2/3, living in the low and middle income countries. And in 2015, 1 in 4 male and 1 in 5 women have hypertension. and less than 20% of hypertensive patient remains under control. That is only 20 or less than 20% of patient having hypertension remains under control. And it is one of the most important cause of premature death worldwide. And one of the global targets for non-communicable disease is to reduce the prevalence of hypertension by 25% by 2025. In Bangladesh, prevalence of raised blood pressure among adults 18 or more years in 2014 around 25% and 26% in male and female respectively. Now, first hypertension center established by renowned internist Professor HTN Chaudhary. He was head of the Department of Medicine in Dhaka Medical College. He established a center known as Professor HTN Chaudhary Memorial Hypertension Center in Green Road, Dhaka in the year 1984. I was his direct student and I took postgraduate training under him. And I had the opportunity to work there in that center for several years during my postgraduate training time. At that time, I understood the impact of hypertension, uncontrolled hypertension on various target organs and health. So, Professor HTN Chaudhary is my inspiration for establishing this center. This center, Hypertension Research Center Rangpur, established in 2008 when I was in Rangpur Medical College as Professor of Medicine. And till today, more than 25,000 registered patients in the center. Regarding hypertension, there are a lot of misconceptions in the society. One of the most important misconception, this disease লক্ষণ নেই কেন চিকিৎসা করব, as this is asymptomatic disease at least initially. এবং আরেকটি মিসকনসেপশন, ওষুধ একবার শুরু করলে সারা জীবন খেতে হবে, সো এত তাড়াতাড়ি শুরু করার দরকার কি, একটু দেরিতেই শুরু করবে। অনেক মিসকনসেপশন রিগার্ডিং ট্রিটমেন্ট, যেমন টক খেলে ব্লাড প্রেশার ভালো হয়, অনেকে তেঁতুলের রস খাচ্ছেন। আবার লবণ খাওয়া যাবে না, তবে ভাজা লবণ খেলে পানিটা চলে যায়, এটা খেলে কোনো ক্ষতি হবে না। সো রিস্ক ফ্যাক্টর একটা সল্ট, এটা কন্টিনিউ করে। এছাড়াও মোস্ট অফ দ্য পপুলেশন হ্যাভিং রং পারসেপশন যে অ্যালোপ্যাথিক ওষুধের অনেক সাইড এফেক্ট, তো অল্টারনেটিভ মেডিসিন গ্রহণ করলে প্রেশারটাও কন্ট্রোল হবে, সাইড এফেক্ট হবে না। সো ডিফারেন্ট অল্টারনেটিভ মেডিসিনের প্রতি মানুষ খুব আকৃষ্ট হয়। Another misconception, hypertension ওই কোনো তো লক্ষণ নেই, আবার ওষুধ খেলেও দেখা যায় তেমন কোনো ভালো লাগা খারাপ লাগা কোনোটাই নেই, সো কেন আমি ওষুধ খাবো? আরেকটা জিনিস, one of the important component of treatment of hypertension is lifestyle modification. This is very difficult and most of the patients consider it is not treatment. Treatment is only tablet or capsule or injection. So lifestyle follow-up modification most of the patient পছন্দ করে না অথবা ইগনোর করে। So for this lot of misconception, there are poor adherence to treatment or significant number of dropout from treatment or significant number of default of patient. So another cause of poor adherence is cost of the treatment, doctor consultation fee, lab investigation fee, এবং medicine cost. At the same time, some of the medication have some side effects. So, ওষুধ খাবো কি দরকার, শেষে আবার পার্শ্ব প্রতিক্রিয়া হয় কিনা হতে পারে। এবং in most of the instances, patient goes to the doctor's center, consult with the physician, and take a prescription. But in this section, lifestyle modification, counseling, I think, not apply for quantity. So, lack of motivation, lack of advice regarding lifestyle modification and personal physician center definitely অনেক কম। যার জন্য অসুখ সম্পর্কে এর কমপ্লিকেশন সম্পর্কে রোগীদের তেমন কোনো ধারণা থাকে। এই সমস্ত all this create a great challenge in managing hypertension. And due to great challenge, and what are those challenges? Increasing number of uncontrolled hypertension patients and huge number of patients, as prevalence is more than 25% in adult population. So, huge number of patients, significant number of uncontrolled hypertension leads to target organ. So, এই সমস্ত চ্যালেঞ্জ ওভারকাম করার জন্য লাইক ডায়াবেটিস সেন্টারের মতো সারা বাংলাদেশে আমি মনে করি should establish hypertension corner or center, যেখানে our patient can get treatment at minimum cost or without cost, এবং যেখানে ট্রিটমেন্টের পাশাপাশি lifestyle modification awareness program will take important role in managing hypertension. This center doing a lot of activities. Number one, increasing awareness program in different sectors, treating hypertension patient on outdoor basis. In addition to this, lifestyle modification audio visual counseling to each and every patient and their family members, so that patient নিজে এবং তার family member দ্বারা treatment পেতে সহযোগিতা। At the same time, this center doing some academic activities. Already started certificate course on hypertension, started short course on research methodology and biostatistics, and doing research alone and along with other institutions like we started research activity.
Assalamualaikum, sir. স্যার একটু মানে ইয়া করি স্যার, ইন্টারাপ্ট করি স্যার, আপনার কথাটা একটু ভেঙে ভেঙে আসছে আর কি স্যার, তো একটু কি স্যার এই মাইকটা স্যার কাছে নেবেন কিনা আর কি স্যার।
This is the first in short, sir, what actually done in the center.
আমার মনে হয় যে নেটওয়ার্কের সমস্যা হচ্ছে, নেটওয়ার্কটা সিঙ্গেল, কথা ঠিক আছে, তার মাইক্রোফোন সবকিছু ঠিক আছে, আপনি কন্টিনিউ করেন, আমরা শুনতেছি, পারতেছি শুনতে ইনশাআল্লাহ। জি,
is the proof, sir. Patient having hypertension can get registration in this center, and senior medical officer used to see the patient, and if they think should be consulted, then they refer the patient to consultant. In every Friday from 10 a.m. to 9 p.m., I used to stay there and see the registered patient free of cost in every Friday. And in other days, in the evening, some of the consultants routinely sit there for their practice, and in addition to their practice, they also see the registered patient free of cost. These are some activities of the center. Now, I am discussing some practical aspects of patient management. The patient, case number 1, this patient, 25 years, unmarried female. First time came to the center for registration, and we found high blood pressure with large disease. Ultimately, she is diagnosed as hypertension, diabetes, ischemic heart disease, and stroke. We referred him to Frankfurt Medical College Hospital for further management. And after improving the condition, she is advised to come again to the center for follow-up. Another patient, 52 years male, known hypertensive for last 5 years, presented with uncontrolled hypertension, and he is registered patient of this center. But pressure তার কন্ট্রোল হচ্ছে না। অন কোয়েরি দেখা গেল উনি ওষুধ রেগুলার খাচ্ছেন কিন্তু লাইফস্টাইল মডিফিকেশন ফলো করছেন না। আমরা তাকে আবার কাউন্সিলিং করলাম, সাবসিকুয়েন্ট ফলো আপে দেখা গেল তার প্রেশার কন্ট্রোল হয়ে গেছে। সো এই যে লাইফস্টাইল মডিফিকেশন ইজ ভেরি ইম্পর্টেন্ট। মেল পারসন পেশেন্ট আমাদের সেন্টারে আসলো এবং তার হিস্ট্রি হলো he is hypertensive, taking multiple drugs, but pressure not controlled. Anal physical examination shows there is rate of hemorrhage. He is diagnosed as case of another patient, female patient, 45 years old. First visit, he came to the center. At first, she is diagnosed as hypertension by a village doctor, and he started amlodipine and olmesar. Came to us with dizziness and fatigue, and we found her blood pressure 90 by 60 millimeter of mercury. We stopped medication, ensured follow-up, and finally, she is non-offensive without medication. So, he is not enrolled in our center. Another patient, 60 years male patient, hypertension for last 20 years. He is also diabetic. কিন্তু তার চিকিৎসা উনি নিচ্ছিলেন না। আমাদের সেন্টারের পেশেন্ট অনেকদিন পরে আসলেন with respiratory distress and anasarca, and ultimately diagnosed as a case of hypertension, diabetes, LVF, and end-stage renal failure. He is referred to Medical College Hospital. It's multidisciplinary approach, and he also needs replacement therapy. So, regarding management of hypertension, monthly drug treatment is not sufficient enough. Lifestyle modification, adherence to the treatment is very important. At the same time, routine follow-up is important because sometimes আমাদের রোগীরা যেখানে সেখানে ব্লাড প্রেশার রেকর্ড করে, রেকর্ডটা সঠিক হয়, অনেক সময় সঠিক হয় না, অনেক সময় একটা ভ্রান্ত ধারণা দিয়ে দেয় অনেককে যে প্রেশার অনেক কমে গেছে, ওষুধ দরকার নাই, যেটা তার জন্য পরবর্তীতে অনেক ক্ষতির কারণ হয়। এই সমস্ত হ্যাজার্ড থেকে সরে আসার জন্য, হ্যাজার্ড রিমুভ করার জন্য ইনস্টিটিউশনাল ট্রিটমেন্ট সেন্টার, ইনস্টিটিউশনাল অ্যাপ্রোচ, যেখানে a huge number of patients can get treatment at minimum cost, routine follow-up, যার জন্য আমাদের ভ্রান্ত ধারণাগুলো দূর হবে, আমাদের অ্যাডিয়ারেন্সটা বেড়ে যাবে, আমাদের কমপ্লিকেশন কভার ইন দ্য লং রান আমাদের পেশেন্ট হবে। সো আমার সকলের কাছে অনুরোধ, আমাদের দেশের প্রতিটি ডিস্ট্রিক্ট, ইভেন থানায় হাইপারটেনশন রিসার্চ সেন্টার ডেভেলপ করা উচিত, অথবা হাইপারটেনশন সেন্টার ডেভেলপ করা উচিত, so that our general population সহজে সুন্দর একটা মানসম্মত চিকিৎসা সেবা নিতে পারে। আমরা রিপোর্টটা পেশেন্টদের জন্য সাধারণত কন্ট্যাক্ট করে আবার টেলিফোনে যদি সম্ভব না হয়, অনেক সময় আমরা চিঠি লিখি। ইভেন আমরা হোম ভিজিট রাখছি, বিশেষ করে যারা কাছের পেশেন্ট, এটা সম্ভব হয়ে ওঠে। আমি ধন্যবাদ জানাচ্ছি অর্গানাইজার সেন্ট লুইস ইউনিভার্সিটি বাংলাদেশ ডিভিশন এবং আমি ধন্যবাদ জানাচ্ছি আমার শ্রদ্ধা শিক্ষক আমাদের সাথে Hypertension and Hypertension Center. Thank you, sir. Thank you all.
Thank you, sir, for sharing with us your beautiful experiences in simpler form. স্যার এই যে এত বড় একটা কাজ করছেন এবং শুধুমাত্র ওনার হচ্ছে ইন্ডিভিজুয়াল এক্সপিরিয়েন্স এন্ড ইন্ডিভিজুয়াল রেসপন্সিবিলিটিতে স্যার আমাদের মানে পুরা ডক্টর সোসাইটি ফিজিশিয়ান সোসাইটির জন্য একটা এক্সাম্পল, ভেরি গুড এক্সাম্পল। আমরা সবসময় প্রে করি এবং স্যার যাতে এটা খুব সুন্দরভাবে মেনটেন করতে পারেন এবং ওনার দেখা দেখে আমাদের যাতে আরো কিছু এরকম রিসার্চ সেন্টার গড়ে উঠুক। আমি কোশ্চেন আনসারে আসলে খুব একটা কিছু পাচ্ছি না। শাহাবুদ্দিন স্যারের দেখলাম প্রথম দিকে 2টা কোশ্চেন আছে। একজন স্যার একবার লিখেছেন যে আমরা হাইপারটেনশনটাকে কিভাবে ডিফাইন করতে পারি, আর আরেকটা কোশ্চেন স্যার করেছেন যেটা হচ্ছে কি যে থ্রেশহোল্ড ফর দ্য ইনিশিয়েশন অফ ট্রিটমেন্ট ফর হাইপারটেনশন। স্যার এই 2টা কোশ্চেন শাহাবুদ্দিন স্যার করেছেন আমাদেরকে। তো নজরুল স্যার কি আনসার দিবেন?
ঠিক আছে। অ্যাকচুয়ালি দুটো জিনিস হলো যে হাইপারটেনশন যে একটা খুবই ইম্পর্টেন্ট কোশ্চেন, শুধু তাই না একটা বার্নিং ইয়েও বটে, মানে কন্ট্রোভার্সিও বটে। তো এই হাইপারটেনশনের ডেফিনেশন আর কি, তো এটা শুরুর দিকে যেটুকু আমি আলোচনা করছিলাম যে আমরা হাইপারটেনশন কিন্তু খুব অতীতে আমি যাই নাই, কারণ অনেক আগে থেকে কিন্তু একটা সময় ছিল যখন হাইপারটেনশন ওয়াজ ডিফাইন্ড অ্যাজ 170/100, অনেক আগে আর কি। তারপর থেকে বিভিন্ন সময় হাইপারটেনশনের লেভেলে কমে এসে আপনার যে জিনিসটা দাঁড়িয়েছে সেটা হলো এই। তারপর এখনকার বার্নিং ইস্যু হলো দুটো নিয়ে আর কি, ওয়েদার উই শুড ডিফাইন হাইপারটেনশন অ্যাজ এ পারসিস্টেন্ট হাইপারটেনশন অর নট। নাম্বার হাইপারটেনশনকে একটা সিম্পল ডেফিনেশন মনে রাখতে হবে। এই ডেফিনেশনটা অনেক আগে থেকে দেওয়া হয়েছে, বিকজ হাইপারটেনশন ক্যান নট অলওয়েজ বি ডিফাইন্ড বাই নাম্বারস অনলি। সেই জন্য হাইপারটেনশন একসময় WHO ডিফাইন করেছিল যে হাইপারটেনশন হবে ওই ব্লাড প্রেশার, হাইপারটেনশন উইল বি দ্য লেভেল অফ হাইপারটেনশন যেখানে ট্রিটমেন্ট যদি না করা হয় তাহলে হাইপারটেনশন কমপ্লিকেটেড ইস্যু হতে পারে। একটা ভেগ ডেফিনেশন ছিল আর কি, এবং সেটাকে পরে নিউমারিক্যালে নিয়ে এসে অনেকদিন ধরেই আমাদের হাইপারটেনশন রেঞ্জটাকে ধরা হচ্ছিল অফিস ব্লাড প্রেশার 140/90 কিন্তু বিভিন্ন ধরনের আউটকাম স্টাডি এটা সেটা দিয়ে শেষ পর্যন্ত দেখা গেল আমেরিকান কলেজ অফ কার্ডিওলজি এই 2017-এ এসে ওনার একটা ড্রাস্টিক পরিবর্তন করলেন। একটু আগেও আমি আমার প্রেজেন্টেশনের সময় বলছিলাম সেটা হলো যে এই জিনিসটা কিন্তু সবাই, প্রথম কথা হলো ব্রিটেন, ইউকে অ্যান্ড ইউরোপিয়ান ইউনিয়ন টোটালি এটাকে রিজেক্ট করে দিয়েছে, ওরা করেনি। ইভেন আমেরিকান সোসাইটি অফ হাইপারটেনশন এটাকে সরাসরি ওইভাবে গ্রহণ করেনি আর কি, এবং ইন্টারন্যাশনাল সোসাইটি বাধ্য হয়ে শেষ পর্যন্ত একটা দিয়ে এবং এই গাইডলাইনটা তারা দিয়েছে।